I'm going to give a talk on the different techniques to get into the coronary sinus. And, I realize that there's more than one way to skin a cat. There's more than one way to get into the coronary sinus. And I'm not going to pretend to tell you that, my way is the best way. There are many, many different ways. And I'm going to show you a technique that sort of I find quite useful. So so it's implanting the LV lead, the coronary sinus lead. I tend to do it after I implant the RV and the RA leads. And the reason for that is, yeah, sorry, maybe there's just a little bit of background noise. If you can just
There's
mute your, if
somebody
you,
somebody called Elvis or whoever's manning this. Can you mute your mic, please? Thank
there we
you.
go. That's better. Yeah, so I tend to implant the CS or the LV lead after I implant the RV and the RA leads first. And I think there's several reasons for that. One is that these patients usually have left bundle, pre-existing left bundle branch block. So, manipulating a coronary sinus guiding catheter in that region, sometimes you can knock the right bundle and then the patient goes into complete heart block. And it's quite an unpleasant thing because, you've got someone who's got a cardiomyopathy, they then go into complete heart block and they can quickly deteriorate on the table. So I tend to have the RV lead in already with the RA lead. I always think that the most difficult part of the CRT implantation is the LV lead. So, I don't want to put the LV lead in and then do the RA and then do the RV because, sometimes if it takes a long time, you're tired and you don't want to put, spend, you wasted energy doing the RA and RV afterwards. So there's less to do after you insert the coronary sinus. And I think it also helps me because the RV lead, if you're putting it in sort of like the lower septal apical region, it helps me locate the septum in the LAO view. So I know more or less the rotation of or where the septum lies. So I know when I'm crossing the septum, so to speak, to get across into the coronary sinus. So those are some of the reasons why I do it after the RA and the RV lead. They form the LA sort of like in an LAO view. Here's what this is what it'll look like. So it'll be a decapolar catheter. So and remember, we're reading signals here from the distal tip. And here's your outer sheath over there. All right, so I'm going to advance it into the right atrium. All right. And what I'm going to do now is I'm going to look and so here's the ventricular EGMs. All right. And here I've got a good position of these are what you want to see. You want to see. What I haven't shown you is I've advanced it into the RV. I've maintained the counterclockwise torque. I've pulled back until I see these signals. Right. And what you're seeing here, these are atrial signals. So that you can see how big the atrial signals are corresponding with the P wave there. And these are the blunt ventricular signals. Now that's a good sign. That tells you that I'm at the annulus. I'm at the atrioventricular groove. That's normally where the coronary sinus is located. If I'm in the ventricle, I'm too ventricle. I'm not going to find it there. And if the atrium is too big with no V's, then I'm too much in the atrium. So you can use the signals that you have to help you get into the coronary sinus. I do know some individuals that don't use signals, and you can probe with just the decapolar catheter, which is you can do. But I find if you've got the signals, it just gives you free added information to get into there. If you've got an EP recording system, this is what you'll see. All right, so you'll see I've got signals on all the 10 bipoles now. So you can see how sharp these atrial signals are in the far field, what they call ventricular signals. And this is what you'd expect to see when you're in the coronary sinus, right? Big atrial signals, small ventricular signals. If you just had the distal two electrodes, you'll see CS1 and 2. That's what you'll see on the analyzer and on the analyzer. All right, so you want to see these big A's, small B's. And at that point in time, advance the catheter forward. All right, so here I am now, okay, on the RA or in the PA view. All right, I've seen the atrioventricular signals, and at that point in time, I'm just going to advance that catheter forward. And you can see that it's advanced. Then once I've done that, sorry, this is not showing. It's not showing all that well, but you can just see a glimpse there. I've gone to the LAO view. So let me just come back there. Okay, I've gone to the LAO view. I've crossed the spine now. All right, and there I'm advancing the outer sheath over the catheter, and I'm withdrawing the catheter. So I know I'm in the coronary sinus. All right, so that's the LAO view. I've moved now to the LAO view to check that I've crossed the spine. Okay, here's another way. All right, even the RAO, you can see sometimes the clue is that there's a little hinge point here, this little buckle. All right, at that buckle is actually where the os of the coronary sinus is. Right, so here's the patient who's had a previous mitral annuloplasty ring. So I know that the atrioventricular groove is in that region. So I've advanced the decapolar catheter in, and then as soon as it's in there and I've seen the atrioventricular signals, I'm going to advance the outer sheath over the decapolar catheter. Okay, here's another example. This is a bit of quite a tortuous, high takeoff os. Okay, here's the midline, the LAO view now. So I've crossed the midline. You can see in the LAO view, if you cross the midline, you're definitely in the coronary sinus. So I've advanced the decapolar catheter around. Great. And then after that, I'm going to advance the sheath through over. Okay, so that's the technique that I use to get into the coronary sinus. Some people might ask, does it cost a lot? Well, we reuse our catheters, so we re-sterilize our decapolar CS catheter. So, I use it until it breaks. So basically, it's a solid catheter. So, sterilization carries very, 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 very low risk for infection. So, we reuse it until it breaks. And you don't need an EP recording system. All right, so the CS cannulation without a steerable catheter. All right, so here's an example of how you would do it. Here's a biotronic sheath. Here's an inner coronary catheter. And so what we're going to do is we're going to try and so this is another technique that you can use. I don't use this anymore. I find it sometimes that you might end up using quite a lot of dye. That you can imagine the Tabezian valve being here. It's quite difficult sometimes to advance it across. But certainly you could use this if you didn't have if you decide not to use this the CS catheter. What you can do is you can probe with a wire, right? So here is the outer sheath. Here's your wire. Okay, you can inject dye here. In fact, we're going to probe with the wire here, and eventually it goes through. So you've seen as it goes through there, you're in the coronary sinus now. Now you can advance your can. I find this is quite difficult, partially because using a wire with quite a curved tip, it's quite difficult actually to advance it through the coronary sinus os. But if you might have good stability, and then you can advance the sheath over the wire. Okay. Here's someone with a high takeoff. So here the operator is using the AL1 inner diagnostic sheath, and you can see there it's quite a high takeoff, and you can you can imagine it's quite difficult to get in here. So we've used a inner sheath to cannulate the coronary sinus. Here's the coronary sinus lighting up now, and then you can put a wire through there, and then through the wire you can advance the inner sheath, and then over the inner sheath you can advance the outer sheath. Okay, so here's the AL1 catheter again. All right, it slipped quite nicely in using a wire. Right, as soon as the wire's in now, you can advance that inner diagnostic catheter forward, and then over that you can advance your sheath. Okay, so this is one option that you can use. Another option that you can use. You see what I mean by having the RV lead in first. So I know the septum is lying over here. So I know that when I'm crossing the septum, I know I must be in the coronary sinus. Right? So that's a clue that this is where the RV septum lies. Yeah, so there's it's going through, and eventually you're going to be able to advance the outer sheath over it. Okay. All right, then so it's just some words about the Worley CSG system and the braided core system. Okay, so what the system uses is a dye injection approach. There's no signals, so it's purely dye. It's got what we call an inner braided core, which is this blue catheter that fits through a 9 French outer CSG sheath. And this sheath is quite nice because it extends right outside the skin. And what you do is you do the same principles as what I've done, but the design of this of the CSG sheath is quite designed to fall into the coronary sinus. So what you do is you use the braided core. You can inject dye through the braided core, and you can spurt contrast through the braided core. And as soon as you see the dye filling the coronary sinus, at that point in time, you can advance the braided core into the coronary sinus, and then over that, you can advance the outer CSG sheath. And the design is quite nice because the design is it's quite it's a lot of thought's been given into it to get you in there. The advantage of using this system is that it's a telescopic, what they call a telescopic system. So sometimes you might find a situation where you have your, let's say your EP catheter in the coronary sinus, and you can't advance the outer sheath over it because the outer sheath just won't advance through it. Either there's too much angulation of the coronary sinus, or you can't do it. This is where this can be quite useful, because what you can do is you can advance an they call it a vertebral vein selector, which is this catheter over here, this inner catheter, through the braided core. So you've got really like a telescoping system, and you can imagine that will give you extra stability. So you can put then a very stiff inner wire, okay, to as a like a mailman, as to hold it, and then through there you put your over that you insert your vertebral vein selector. Over your vertebral selector you've got your braided core. Then over the braided core you've got your CSG sheath. So you've got like 4 telescoping structures that you can use and it tends to be quite stable to advance to get into the coronary sinus. So this is something that you can use for a situation where you can't advance the outer sheath over a diagnostic catheter. All right, then I just finally, I thought I'd spend some words about the left bundle branch area pacing sheath. And this was a case we did a few weeks back where we couldn't advance so here's the RA lead, here's the RV lead. We couldn't advance the steerable CS catheter into the coronary sinus. It just we just couldn't get it in. All right. And what we then did, we actually wanted to then do default to left bundle branch area pacing because I couldn't cannulate the coronary sinus. All right. So here's a video. You can see that for some reason with this catheter just wouldn't, this is riding up the septum here, not into the coronary sinus. It just wouldn't cannulate the coronary sinus. And in fact, what happened is we then took a left bundle branch area pacing sheath. This was I think, a Biotronic system. And what we did there was we then gave contrast. All right, and if you just see that, let me try to play that again. There we go. You can actually see that the reason why we couldn't get in was that it was quite a high takeoff coronary sinus. You can see it coming down here and then it goes up. And we were just with the steerable CS catheter, we were probing and pushing in this direction, but we couldn't get the catheter down here. So what this thing allowed, this left bundle area pacing sheath allowed us to do is actually visualize with contrast the coronary sinus. And when we did that, we were able to then pass I took a Terumo wire in there. You can see that we were able to then cannulate it, and you'll see it coming around. There's the coronary sinus here, and it's going to come eventually around there. And then, in fact, this lead, where it fortuitously went into a sort of a posterolateral branch, and with that, there we go. You can see it advancing. Then over that wire, we kept the wire there just for stability. We took the inner PTCA wire, whisper wire, and through that, then we advanced the quadrupolar lead. All right, so this is the one where we used a left bundle branch block area pacing sheath to get into the coronary sinus, which was proved to be quite useful because we couldn't get into it with the conventional techniques. So it's and I don't think it's just anecdotal, because several times when we've gone to put in a left bundle branch area pacing lead, we would inject dye and find it be in the coronary sinus. So I think it's that tip that the design of the tip that faces the catheter medially that I think helps you get into the coronary sinus. Difficulties with CS cannulation. I think this was a useful paper, which I thought was quite useful. And the normal heart in a normal heart, looking at it from the bottom. So you're looking at the bottom of the ventricles. Here's the inferior vena cava over here. It looks like a T. So the coronary sinus would be over here. This the PDA you'd imagine lies here, and the right coronary artery would lie over there. It tends to follow a T configuration in the normal heart. Now, as the heart gets bigger, for example, with a dilated cardiomyopathy, that T becomes a Y. All right. So, and that's the difficulty sometimes is that the coronary sinus then takes a sort of a posterior, um, a posterior directed run, a course. All right. And that's the sometimes what people forget. So what you have to do sometimes, and I find this um, quite commonly in big hearts, is that you actually, when you're withdrawing back and maintaining that counterclockwise torque, you actually have to face the catheter quite posteriorly because of the Y configuration that develops. And it's no longer a T, it becomes a Y. And the trick is that you have to maintain that counterclockwise torque, facing it almost backwards before advancing it forward in the RAO view. Okay, so here you can see quite a posterior takeoff because of the Y configuration of the coronary sinus in someone with dilated cardiomyopathy. Yeah, so just much similar. So here's just two examples from a paper that was written about the easy. You can imagine this is an easy cannulation. You can see that it tends to go, this would be an easy cannulation going forward anteriorly, whereas this would be a difficult cannulation because the direction of the coronary sinus is facing posteriorly because of the Y configuration. And you can see the difficulties here of getting the lead in because of that. So, you remember to just maintain that counterclockwise maneuver. All right, and I think that's my last slide. So I'm happy to take any questions that you have on CS cannulation and the steerable CS catheter approach.
Hello, Ashley. This is Mervat.
Hi, Mervat. How are you?
I joined you after 15 minutes after you started.
Oh,
But
okay.
this is an excellent explanation, demonstration of difficulties to enter the coronary sinus. I just would like to thank you for this lecture and also to tell the audience you have to have faith that you are going to do it in order to do it. Don't be upset or pessimistic that it's going to fail. If you have this feeling, you will never do any CS cannulation or any implantation of CRT. So we have to have a faith that you are going to do it. I would like to tell you about the case. He was a Libyan patient with dilated cardiomyopathy, and we tried to go into CS. There was no CS actually, but we entered a supradiaphragmatic extracardiac vein, which was all around the heart. And I could not believe that it was it. I thought that I'm in the pericardium, but it has branches. And did you find such case before? I had it twice in my life.
Is it? Okay. I haven't seen that. Cheers. I've seen a left-sided, obviously a left-sided SVC, which can be quite difficult to put in. But I've not seen that one. I've not seen that anatomy.
Yeah,
No.
I have these two cases which were really very interesting. And I read about it in the Mayo Clinic case report, a book which they make it for revision before exams.
Okay. Wow.
Okay, but yeah.
Difficult. Yeah, so CRT, I always say it's like I always my children play snakes and ladders still. It's like snakes and ladders. You start off
Yeah.
and you think you're gonna get near the end, and then there's that snake
Yeah.
at the top that just bites you, and you have to come and start again. And it's identifying the different difficulties along the way, knowing where the difficulties are, and then negotiating that to get to the end. And the one thing that I try to do is, I try not to spend, if something's not working, I tend to, after 5 minutes, change strategy. Just try something
Yes.
different, because if you're not going to get in with something, try a different one. And sometimes the coronary sinus becomes if you can't get it in relatively quickly with the CS catheter, it gets very soft. So then what I do is I actually take it out and then just get another sterilized one, because I find
Yes.
another sterilized one just is a bit harder, and you're able to get it in a bit. It just gives you that stability that helps. Or just take it out for a while, just let the catheter just get harder again, and
Yes.
then go again. Yeah.
And also using different types of catheter, like the Biosense, the St. Jude, the Boston. And I would like to say that we used this, we used to use the decapolar 5 French Biosense catheter, and we always had dissection within the CS. So I stopped using it, And I use the quadripolar catheter, the non-deflectable, and it works very good, very
Okay.
good. I want to tell the audience also that you have to be ready with the armamentarium. Yani, deflectable decapolar catheter you might need to do it from the femoral vein in order to open the CS and to use you to guide to enter the CS. Also the left amplatz catheter in order to use with the trauma wire. This is what Chelan does in Kenya.
Mhm.
And of course, the injection, and also the most difficult part that you showed, which was the using the guide wire. It was not a trauma wire, and also to introduce to push the sheath over the wire. طبعا the sheath might cause dissection. So if I want to add, you can put the dilator over the wire after you enter, and then push the sheath over the dilator over the wire. This will be safer. And also the audience should remember that PCA wire is not enough to carry the sheath. You can so you have to use the regular 35 wire or 32. You can use either or.